Now that that's over with, I'm going to tell you two stories today. Sorry. The first story is a story about how the structure of South Africa's disability grant system may have undermined its ability to help the health and well-being of those it was supposed to help, in particular those with HIV/AIDS. And the second story is a story of data. It's how understanding our data and our theory allows us to identify this particular issue without using a randomized controlled trial or even a natural experiment. South Africa's disability grant system is a bit unique. On the surface, it's just like most other disability grants. It is income for those who are unable to work due to disability. It requires two things. First, it requires some form of health disability, and secondly, some income threshold. These are extremely important grants among those who are receiving the grant, making roughly 40 to 50% of total household income for grant recipients. What's unique about the South African system is that it's integrated with the HIV/AIDS response. One way to qualify for a grant is to actually be AIDS sick. Before 2008, the de facto definition of AIDS sickness was a CD4 count of 200 cells or fewer. I say de facto because it wasn't official in all places, it varied region to region, but the effective threshold was CD4 of 200. After 2008, it was recognized that this might be a problem for reasons I'll explain in just a moment, and the law disallowed the definition of disability to be a CD4 count threshold. The reason this might be a problem is it provides an unusual incentive. It provides an incentive to manipulate one's CD4 counts, and there are two ways that this might happen primarily. The first way is if I were a patient and I had a CD4 count of 199 and I'm qualifying for a disability grant. I know that a few months from now when I go to reapply, my CD4 will be above 200. I will no longer get that grant. So what I might do is modify my adherence behavior to be above the threshold so that, or I'm sorry, just keep myself below the threshold so that I stay qualified in the future. The second thing that might happen is if I were a doctor and I saw that one of my patients had a CD4 of, say, 201 and was just about to lose their grant status. For their good, I might just change it just a little bit. So instead of writing down 201, I might write down 199. There's sort of two ways that this manipulation might occur. There's a little bit of qualitative evidence to suggest that this might actually be the case. The rough summary of the qualitative evidence, though, is that nobody interviewed has ever said that they personally modify their CD4 count behavior or their adherence behavior, but most people believe it's a problem with other people, which led one researcher, one of my favorite quotes in this literature, to say that the threshold effect appears to be supported by anecdotes and not by research. So that's what we're here to do today. We're going to provide some hard quantitative data that this might have actually existed. We're going to ask two questions. Are individuals manipulating their CD4 counts due to the structure of the disability grant? And did the policy change in 2008 actually change this? So we're going to do this in a setting in rural KwaZulu-Natal. It's a very low-income, very high HIV prevalence region about 2 hours north of Durban. And we're using the Africa Center Demographic Information System. This is a long longitudinal study with very high participation rates, about 100,000 individuals over 10 or 15 years. And it's linked on top of the annual surveys to a bioinformatics system, which gives us full CD4 counts for those who are HIV positive. In particular, we're using data for those individuals for whom we have a lot of CD4 count data, so at least 6 or above, and that gives us roughly 20,000 CD4 count observations over roughly 2,500 individuals. To test this, we need to make a few hypotheses, and we're going to make 4. If there is a grant effect incentivizing manipulation of CD4 counts, we believe that the incentive effect should cause slower CD4 count recovery overall, that those who are on disability grants are more likely to change behavior. The impact will be strongest, specifically around 200, and we'll explore this quite a bit, and that the impact will be less after 2008 when the laws change. So let's think about our data a little bit. So if we were to look at the distribution overall of CD4 counts and there were no manipulation, we'd expect to see something relatively smooth, that there would not be any sort of action around a CD4 count of 200. However, if there were manipulation, we might see something like this. We might see a blip just around 200. That's the technical term, is a blip. We might see some bunching. There should be too many people right before, who are right below a CD4 count of 200, maybe too few people right above. And when we actually look at the data, we don't really see that. If we look at all of the CD4 counts across all patients, across all years, we might see a small bunching right under 200, but it's hard to tell if that's a statistical anomaly. However, if we narrow down a little bit, we look at disability grant recipients only before the laws changed, so before 2009, we see something quite different. We do see quite a bit of bunching just below 200. Now, there are a number of other reasons this might exist, so we have to go a little bit further before we can make a formal test. So when we say that people are spending too much time below 200, this is sort of what we mean. If we're looking at somebody's recovery over time, in the absence of manipulation, we'd expect to see, on average, a relatively smooth recovery rate. There should not be, again, any action around 200. It should just kind of skip right over 200, just like any other threshold. However, if there were manipulation, if an individual was poorly adherent around this threshold, we might see something like this. We might see some flattening. People are spending too much time below 200. And that's the basis of our statistical test here. We want to see, is the rate of recovery less around this threshold among disability grant recipients than would otherwise occur? I'm not going to get into too much detail as to exactly how this, the details of this particular statistical process, but I'll give you some intuition as to how it works. This is a two-stage process. Stage one is not strictly necessary, but it does add quite a bit of robustness and helps us believe that everything else has worked properly. So what we do is we take an overall rate of CD4 count recovery per each individual. And we can difference that out of our second stage. Now, what that allows us to do is, if we are worried about disability grant recipients being inherently different than non-disability grant recipients, we can difference out anything that's fixed to somebody's overall recovery rate. And that's kind of akin to a fixed effects model, where we are differencing anything out that's inherent about a person, that is fixed about a person. The second thing this allows us to do is really isolate the variance that we're interested in. It takes out kind of quite a bit of noise that's not very useful. In the second stage, we can identify a difference in the rate of recovery. So the first stage gives us an equation for every patient that predicts their overall rate of recovery. In this case, we're actually using just a simple log transformation of CD4, which actually just happens to be convenient statistically, as well as fit our data really nicely. We do use quite a bit of other transformations, and I'll discuss that in a moment. So we can take that rate, we can difference it out of our second stage, and we can have a difference in difference, where our effect should be largest for those who are on a disability grant specifically around a CD4 count of 200. And here's our results. So in the first column is our main specification using that natural log transformation for our predictive model in the first column, and down highlighted in red is our main result. What this shows is that those who are on disability grants have a slower rate of recovery specifically around a CD4 threshold of 200 than otherwise. In the second column, we do another test. So we have a difference in difference in the first column. We have a difference in difference in difference in the second column. The differences also along the law change. So we expand our data to allow all patients instead of just before 2009. And what we find is pretty remarkable. We find that the effect still exists in the difference in difference in difference. So in other words, before 2009, that effect exists, which is what we'd expect. But our overall effect disappears. In other words, once the law changed, our effect basically disappears. The law appears to have worked extremely well. In our last column, we changed things around a little bit to have a little bit more of an interpretable coefficient. In the first column, it's very hard to interpret the change in log of CD4 over time. The last column, we can sort of do this in unit rate terms. So what we find is that a person who's on a disability grant has a 30 CD4 per year recovery rate less than should have in the absence of manipulation. And this turns out to be roughly half. So a disability grant recipient causes a person to have their CD4 count recovery for this time specifically around when they're at 200. And again, this disappears after the policy change in 2008. Now this theory, as we said, relies very, very specifically around this threshold of 200. And it's possible that if we miss something statistically, that we would find results for pretty much any other CD4 count above 200 or even below. And so what we do is a permutation test. We pretend for just a moment that instead of a CD4 count of 200 we're looking at, we pretend it's 300, 400, et cetera, all the way across. And what we'd expect, if we're correct, if we haven't missed something, that every other CD4 threshold that we set that is not 200 should be effectively null. It should be 0, and that's exactly what we find. If we start on the left side, that's our original result at CD4 of 200. If we go forward, we see very quickly that the coefficient that we get drops to 0. So these are the 95% confidence bounds. Yes. Just to quickly go over where our results. So we find a negligible threshold effect at the general population level. We find that there is a threshold effect at the before 2008, and the policy change appears to have fixed that. For policy implications, it appears that our policy has worked. We should also consider restructuring this disability grant to yield a positive incentive. So for example, bonus payments instead of negative payments for recovery. And then finally, I'd like to thank the Africa Center, the Wellcome Trust, NIH, and the Harvard School of Public Health, the South African Department of Health, my doctoral committee, and my colleagues at the Africa Center and co-authors. Thank you very much.